Agresti.com on the blog. I talk about in-depth articles about opiate detox. What are opiates? Fentanyl, hydrocodone, oxycodone, meperidine, codeine, heroin, and methadone. With the exception of methadone, I'm talking about all the other opiates. All the other opiates require a 24-hour washout before the detox begins. We need to prep the body for the detox. Before I have people come in, I ask them to hydrate, take electrolytes, take supplements, to eat, to rest, make sure they're in pretty good shape. Then what happens? I have them stop the opiate, whether it be fentanyl, whether it be OxyContin, oxycodone, hydrocodone, meperidine, codeine, those are all the opiates. That covers just about 95%. And just remember, when you're doing this, when I'm doing this, I'm giving you general guidelines here. Remember, anyone who gets put on opiates, it's usually they're put on them for a reason and they become addicted or dependent. They may have back problems. They may have all different sorts of surgeries which have gone bad, reflex sympathetic dystrophy. They may have chronic pain syndrome, ALS. I've had most people have some issue, medical issue that they could put on opiates. And people have coexisting medical problems, and people have coexisting addictions. So just remember, this is a general guideline, and I'm going to discuss how we do it and why we do it. But everyone has a different clinical picture, and there's just no one size fits all, because these are complicated cases with coexisting addictions, coexisting medical problems, coexisting doses. The amount of opiate you're on and the length of time is critical in determining how we'll work this. So the first 24 hours to keep people comfortable, we use lofexidine, 0.1 milligram, 0.18 milligram. We give 3 of those. They're come in tablets in that size, 3 to 4 times a day to block the norepinephrine surge in the body from the withdrawal. And it helps minimize withdrawal without dropping the blood. Leucimira is the name. That's the trade name. Lofexidine is its chemical. It blocks the excitement of the body from the norepinephrine without dropping the blood pressure. It's an alpha-2 agonist. Other drugs which work and have been used in opiate detox have been Clonidine. That receptor in particular it activates that receptor, but the receptor is actually inhibitory of norepinephrine release. Other drugs, probenecid, believe it or not, a gout medicine. Doctor in Canada, Calgary, University of Calgary, has used this 500 milligrams twice a day, probenecid, which was initially used for gout, to block the PANX1 receptor, and it minimizes withdrawal. There's another drug which actually blocks an NMDA glutamate receptor and affects dopamine called amantadine at 100 milligrams twice a day. That can block opiate withdrawal. You can use these in the first 24 hours. Also in the first 24 hours, Phenergan can be used, Promethazine. It blocks anxiety and it blocks nausea. That can be used 25 to 50 milligrams three times a day. Just as an aside, the key features of opiate withdrawal: hypersalivation, you salivate a lot, cramping, restless legs, yawning, intense anxiety, craving, nausea. You could get diarrhea, you could get vomiting, you could get sweating. I mention these only that the drugs we're using block all that. Usually nothing happens. People get a little anxious. So besides the Phenergan, you can also use a benzodiazepine like Flurazepam is the one I choose. Sometimes I use Clonazepam, 1 to 3 times a day, 1 milligram, just to back off the anxiety. Also, what could be used is Mirtazapine. Mirtazapine, this is on the first 24 hours. They've stopped opiates. Mirtazapine can help you sleep, could block nausea, and stimulate your appetite, which is another side effect of opiate withdrawal. So during these first 24 hours, it's critical that the patient remain comfortable and have no loss of fluid volume through vomiting, diarrhea. It's critical because that would be high risk then. You lose base if you have diarrhea, and if you vomit, you lose acid. And that throws off your entire body, and it throws off the electrolytes. So you have to be very careful of that. And I'm at this point, 40 years into this, I never let it get to the point where someone has nausea, vomiting, or diarrhea, or sweating. I can ameliorate that. The craving for the opiate, a little anxiety, you're going to experience that. 90% of the withdrawal, you will not. Those are the medicines I use. Maybe Baclofen, 20 milligrams 3 times a day to stop muscle spasms, muscle cramping, or Robaxin, Methocarbamol, 500 to 1,000 3 times a day. So I keep that patient completely comfortable. It's critical because you want to keep the patient comfortable, but you can't have any nausea, vomiting, diarrhea, sweating. I don't want them losing fluid. And then 24 hours into it, I have them take their first buprenorphine, usually at 2 milligram, test the waters. And then I do sublingual. I use the film because I could titrate the dose by cutting it any which way. I use an 8 milligram film. It dissolves on your tongue. And that, once your body's accepted the first buprenorphine, the Subutex, the risk of this is over now. At that point, say 24 hours, 28 hours into this, that person who's accepted buprenorphine, their body and their receptors are kind of in a safe place for me to manipulate. And I may have to go to 8 milligrams, 16 milligrams, 24 milligrams in a day, maybe even 32. But then I bring it right down. At day 2, for sure everyone's at 8 milligrams twice a day. We're almost 90%, 95% of the receptors, the opiate receptors are blockade. There's a blockade on them. Blockade, I shouldn't say that they're stimulated. The difference is an opiate receptor, when it's affected by an opiate, is activated. But buprenorphine, it grabs on tighter than an opiate, but it doesn't stimulate it. But it prevents withdrawal. And then from there, over the next 5 days, I titrate down. On day 6, then I restart the secondary medicines. Probenazine, amantadine, lofexidine, clonidine, Robaxin, Baclofen, Flurazepam, Clonazepam, Mirtazapine. I would use those as needed depending on the symptomatology of the opiate withdrawal. At that point, the detox is over at day 4. So day 5, day 6, the detox is basically over. You're dealing with post-acute withdrawal. Now the most common thing that begins now in post-acute withdrawal is fatigue and craving for the drug and inability to sleep. So what I wind up doing, I may start Provigil, I may start Nuvigil to give them energy because they're very apathetic. Fatigue is a serious problem. Sunosi is another thing that I use. Solriamfetol. The other drug, Nuvigil and Provigil, is modafinil and armodafinil. So that would give you pick-me-up. You could still have some symptomatic withdrawal or elevations in norepinephrine, gives a patient an agitated or anxious feeling. I can continue to use lofexidine, but I back the dose way off. 0.18 3 times a day, not 0.18 3 times a day. And I would use something for sleep, either Promethazine, Mirtazapine, possibly for a couple days, no more. I use maybe 5 doses combined of a benzodiazepine like Flurazepam or Clonazepam. After maybe day 7, day 8, the need for meds, secondary meds, goes way, way down. I usually just use a stimulating drug like Provigil, Nuvigil, Sunosi in the morning, and a sleeper at night. At that point, I give maybe trazodone, Cinequan, Mirtazapine at night. I don't like using Mirtazapine after day 7 because it stimulates appetite and people gain weight. So I would probably go to a Cinequan, a trazodone, possibly even giving a bigger dose of lofexidine at night. And with that, I follow that patient over probably a couple months because the sleep problem, the craving problem, the energy problem usually lasts 3 weeks. Sleep problem usually lasts 2 months. And then we're good. That's basically the follow-up on opiate detox. Please, if you're still watching, Dr. Mark Agresti, go to my blog. I have posted maybe in the past 3 months 100 articles. I do a lot of research, keep myself updated. Check it out. Thank you.